Are you feeling nauseous? Tossing your cookies on the regular? Well, don't worry, you're not alone. Today on the She Found Health podcast, we're going to talk about nausea and vomiting of pregnancy and break it down for you. We'll talk numbers, how many women typically get it, at what time during the pregnancy, and for how long it lasts. We'll talk about what causes it, what we want you to tell us about your symptoms, and why we start treating it early. We'll also discuss the treatment options we have, including pharmacotherapy, so medications, and non-pharmacotherapy, so more diet and lifestyle changes, and when it's serious enough to require hospitalization.
Welcome to the She Found Health podcast. We are Doctors Sarah and Alicia. We're maternity doctors who are passionate about caring for women and young families from conception through the first few challenging years of parenthood.
We have 5 kiddos between the two of us, so we get it. We've been there. And we made it through to the other side, and now we want to support you through your journey.
We are delving deep into topics to prepare you to have the healthiest pregnancy possible, the best birth you can, and to thrive rather than just survive during the newborn and postpartum phase.
We want to remind you that the information that we share is meant for general medical information only. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. The information we share may not apply to every situation. If you have questions or if you've received different advice, please contact your healthcare provider. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition.
So let's start by talking numbers. Nausea and vomiting usually starts between 5 and 12 weeks of pregnancy, and is quite common. Up to 80% of pregnant women experience nausea and vomiting at some point in their pregnancies, and between 3 to 6% of pregnant women experience severe nausea and vomiting, which we commonly refer to as hyperemesis gravidarum. The symptoms usually peak around 9 weeks and typically improve by week 16 to 18 of pregnancy. Unfortunately, for some women, these symptoms actually persist through pregnancy. Up to 20% of women have symptoms until the 3rd trimester, and for an unfortunate 5% of women, their symptoms persist until delivery. But just because it's common doesn't mean it's something that women just have to deal with. In fact, it's quite the opposite.
Hey Sarah, did you have any nausea and vomiting in your pregnancies?
Oh girl, I sure did. Diclectin was my best friend. How about you?
I didn't, except for one day when I was working with a colleague of mine that had horrible nausea and vomiting, and I think I had sympathetic nausea and vomiting of pregnancy. No vomiting, but just the nausea. It only lasted about 10 minutes. I was pretty lucky. But nausea and vomiting of pregnancy can significantly impact your quality of life and your mental health. It can increase your anxiety and worry about how it's affecting the fetus and how it's affecting your ability to work, and it can also impact your relationships. Now, the thing is, even if it's just mild, we want to know about it. Sometimes women don't mention their symptoms to us, worrying that they're too mild and they'll just be brushed off, or worrying that they'll be offered medication, but they don't really want to take medication in pregnancy.
So why do women get nausea and vomiting in pregnancy? Believe it or not, the cause of nausea and vomiting in pregnancy is not entirely understood. Hormonal changes are thought to play a significant role, including elevated levels of estrogen, though the rising level of beta-HCG, human chorionic gonadotropin, or what we commonly refer to as the pregnancy hormone, which peaks in the 1st trimester, is thought to significantly contribute to the symptoms as well. Additional theories include abnormal gastric motility, meaning your stomach may empty more slowly than usual.
So why do we want you to tell us about it? Well, we want to help you. Even if your symptoms are mild, we've got so many tips and tricks to help you manage your symptoms, and most of them are not actually medications. Also, because nausea and vomiting of pregnancy, aka morning sickness, is what we call a diagnosis of exclusion. What this means is that we as your care providers need to make sure that there's nothing else going on causing your symptoms. Just because you're pregnant doesn't mean that we're going to simply brush off your symptoms. We need to review your symptoms and ensure that we're not concerned that there could be something else at play contributing to how you're feeling, like thyroid abnormalities or side effects of another medication or substance use. Marijuana can certainly cause nausea and vomiting, and we'll talk more about cannabis use in another episode. But chronic use can actually be an underlying cause for nausea and vomiting. Additional things we need to exclude are infection, underlying eating disorders like anorexia or bulimia, and several other less common causes like migraines and rare hormonal causes. Are you newly pregnant or thinking about becoming pregnant? Well, check out our free Preparing for Pregnancy guide, and you can find it at www.shefoundhealth.ca/preparing for pregnancy. We put it together for women who are thinking about getting pregnant or newly pregnant to really kind of get things off to the best start.
So, how do we diagnose nausea and vomiting of pregnancy? Typically, it's diagnosed by a process of elimination. It must onset or start in the first trimester, and we have to exclude other possible causes of your symptoms, as we just described above. If your symptoms start after the first trimester, then we'd be more suspicious that something else may be going on causing you to have nausea and vomiting.
So why do we want to start treatment early? First of all, we want to be clear that treatment does not mean that we need to start medication right away. Treatment strategies, which we'll discuss next, include pharmacologic, medications, and non-pharmacologic, so lifestyle and dietary modifications that you can make. The reason we want to initiate treatment early is to help you get your symptoms under control as early as possible. If we start treating early, it's possible that we may prevent more serious complications like dehydration, weight loss, and the need for hospitalization. Additionally, if we delay treatment until your symptoms are severe and you're experiencing complications, it can be way harder to get those symptoms under control.
So, what treatment options do we have? We're going to break treatment options down into two categories. Like we said, non-pharmacological, so not medications, and pharmacological, that includes medications. We'll talk about both, starting with non-pharmacological. A big thing that you can start right away is making dietary changes. Little tips and tricks we often tell our patients are eating before or as soon as you feel hungry to avoid an empty stomach. Oftentimes, having a small snack on your bedside table to have before you get out of bed can be a helpful strategy for women whose nausea is worse first thing in the morning. Some women find protein more tolerable than fats and carbohydrates, so make sure you include lots of protein in these snacks. Also, eating smaller meals and eating more slowly, as usual, to prevent an overly full stomach, worsen nausea. We also recommend avoid lying down right after meals. Another trick is to try and drink your water between meals. Again, this is to minimize the effect of an overly full stomach, and try and avoid drinking too many fluids during meals if possible. Now, drink what tastes good for you, but most common fluids that are best tolerated include cold, clear, and carbonated or sour beverages like ginger ale, lemonade, and even popsicles. And make sure you do take these in small amounts. Another trick is to try sniffing fresh lemons, drinking lemonade, or eating slices of watermelon.
So what Dr. Sarah is saying is walk around with a cut-up lemon in your pocket. No, that's not true. But I just wanted to interrupt here for a moment. I was listening to a podcast the other day. Yes, I listen to podcasts for medical information as well. And it was about a dietitian, and she was discussing nausea and vomiting in pregnancy early on. And her tip was, if you can combine some protein with your carbohydrate first thing in the morning, then you're not going to have those big spikes of sugar and then drops later, which can cause even more nausea. We produce more insulin in early pregnancy, and so our blood sugars are low, which is why we're craving these carbohydrates. But if you can choose something with a bit of protein, so crackers and cheese or apples and peanut butter or cashews are a good option too, then you'll actually stabilize your blood sugars a little bit more and fend off that nausea just a little bit.
That's a great tip.
Thanks,
Alicia. Another thing that we can do is try and avoid triggers. Now, everyone's triggers are going to be different, but some common triggers include stuffy rooms and certain odors like perfumes, chemicals, certain foods, and smoke. A few other common triggers include heat, humidity, noise, and visual or physical motion, so flickering lights or driving in a car. Excessive exercise and excessive fatigue can also contribute to worsening your symptoms, as well as foods or snacks that are high in sugar, spicy foods, and high-fat foods.
So fatigue can also worsen nausea and vomiting in pregnancy. And we know that sleep requirements increase in early pregnancy. We as healthcare providers have a liberal approach towards recommending increased rest and leave of absence from work to support women through severe nausea and vomiting in pregnancy. Brushing your teeth after a meal or spitting out extra saliva, frequently washing out your mouth can also be helpful. Switching to a different toothpaste may help women for whom strong mint-flavored toothpaste is a trigger. So supplements containing iron should also be avoided until your symptoms get better, as iron-containing supplements can cause irritation to your stomach, which worsens nausea and vomiting. One tip that I often tell women is to switch their prenatal vitamin over to a kid's chewable vitamin and a folic acid supplement. So we recommend about 800 micrograms a day of folic acid. We know that ginger is something that many women find helpful for nausea in the form of ginger ale, ginger tea, ginger tablets, or candied ginger to suck on. So if we're prescribing ginger, a dose that we usually prescribe is 1 to 1.5 grams daily, and we divide it over kind of a 24-hour period. So 250 milligrams of ginger capsules orally 4 times a day. In 2014, a systematic review of 12 randomized trials showed that ginger improved nausea compared with placebo, but didn't significantly reduce vomiting. Another tip that we often recommend is acupressure. Now, you can do this one of 2 ways. You can actually go for acupressure and acupuncture treatments. About 30% of women find these treatments can relieve symptoms at the P6 acupressure point. So this is about 3 finger breadths up from your wrist on the inside of your wrist in between the 2 tendons. The other option would be C-bands, which is a bracelet that we use for seasickness that has the same acupressure point as that P6. Now, a surprising one, well, not surprising to us, is mindfulness. So a study actually looked at vitamin B6 alone versus vitamin B6 and mindfulness-based cognitive behavioral therapy, i.e. MBCBT. And this helped women reduce nausea and vomiting symptoms as well as improve symptoms of both anxiety and depression.
One thing that we ask is that you please do not use marijuana, THC, or CBD products. They have not been shown to be safe in pregnancy and are not recommended for treatment. Additionally, long-term marijuana use and withdrawal can actually increase nausea and vomiting.
So let's move on to pharmacotherapy, or medications that we would prescribe. So if the above-mentioned strategies aren't quite cutting it, which is the case for many women in early pregnancy, unfortunately, we often turn to medications that can help reduce symptoms and improve your quality of life. The first thing we generally try is pretty simple, vitamin B6. It's also known as paroxetine. It's a water-soluble vitamin that has an excellent safety profile, and given that it's a vitamin, many women are comfortable starting here. We usually recommend a dose that is 10 to 25 milligrams by mouth every 6 to 8 hours, so 3 or 4 times a day. The maximum dose that we recommend in pregnancy is 200 milligrams per day. Studies have shown that it can be effective at improving mild to moderate nausea, but doesn't really reduce the vomiting component of it. Our next go-to is vitamin B6 combined with doxycylamine succinate, which is known as Diclectin in Canada, or Diclegis or Bongesta, I don't know how to say those, in the United States. Doxycylamine is a first-generation antihistamine, and paroxetine, which is the combination that it's with, is vitamin B6. So as a combo treatment, it appears to be more effective than either drug alone, and its safety profile has been well established in pregnancy. We start off using usually 2 long-release tablets in the evening before bedtime, and we can bump this up to 4 tablets over the course of the day as you need to. For more severe nausea, we take 1 tablet in the morning, 1 in the mid-afternoon, and 2 tablets before bedtime. Now, it's really important to note about this medication that we use this for prevention, not for treatment. So if you're already nauseous, it doesn't work as well. But if we can give it to you to prevent that nausea, that's great. So if your nausea is worse in the morning, take it before bed. If it's worse in the afternoon, take it in the morning. You get the gist.
So if despite lifestyle and dietary changes in combination with doxylamine paroxetine is still ineffective at managing your nausea, then we typically look at medications targeted to more severe symptoms. The next step after diclectin is often dimenhydrinate, commonly referred to in Canada by its trade name Gravol. It can be taken by mouth and also rectally. Yes, we mean in the bum, every 4 to 6 hours. We often also give this intravenously in hospital for women who are admitted with severe nausea and vomiting in pregnancy.
If dimenhydrinate or Gravol isn't able to get your nausea and vomiting under control, the next medication that we would turn to is called metoclopramide. We know it as Maxaran in Canada. These are dopamine antagonists that aid in stimulating gastric motility and emptying your stomach. So they just basically help things move through a little bit more quickly. This can be taken by mouth, or it can be given through an intravenous or through a shot in your muscle up to 3 to 4 times a day. We have excellent data available that reassures us that this is safe in pregnancy.
So if you've tried a combination of at least 2 of the above medications with little to no improvement in your nausea and vomiting, then we often turn to ondansetron, which is often referred to in Canada as Zofran. This is a serotonin antagonist that we know is very effective. You may have heard of some controversy in this medication in pregnancy due to the possible small increased risk in cleft palate and cardiac anomalies in babies born to mothers who use this drug in the first trimester of pregnancy. Currently, it's listed as a pregnancy category B medication, which means there is no evidence of risk in studies, but this has not been confirmed in controlled studies in women in the first trimester.
So in addition to the above, we often recommend trialing acid-reducing medications because these combined with anti-nausea medications can offer significant improvement in symptoms. Medications commonly used include an antacid like Tums or an histamine blocker similar to ranitidine or cimetidine or a proton pump inhibitor like pantoprazole or esomeprazole. If you're experiencing severe nausea and vomiting in pregnancy, which we refer to as hyperemesis gravidarum, you will likely need to be admitted to the hospital for initiation of your management. Hyperemesis typically presents with women who have persistent vomiting associated with weight loss, low blood pressure, dehydration, and laboratory abnormalities such as electrolyte disturbances. Women are often most concerned not with their symptoms, but how their nausea and vomiting is affecting their baby. Fear not, there is no increase in fetal malformations of infants born to mothers with nausea and vomiting of pregnancy or hyperemesis, regardless of what medications they did or didn't take. There is no difference in birth weight or gestational age at the time of birth for women who are affected by this compared to those who weren't, as long as they had a normal pre-pregnancy weight and they had appropriate weight gain later in pregnancy. So if you're pregnant now and you're wondering when you should seek help, generally we'd recommend seeking help in the following situations. Your symptoms are new and you want reassurance and to review how to manage them.
Your symptoms were previously manageable with non-pharmacological approaches, like we outlined above, but are worsening and you want to discuss next steps.
You're showing signs of dehydration, which is infrequent urination, really dark urine, dizziness when you're standing up, which can also be a very common symptom.
If you're experiencing excessive vomiting throughout the day.
If you're having blood in your vomit.
If you've got associated abdominal or pelvic pain or cramping.
If you're unable to keep any foods or fluid down for more than 12 hours.
If you've had a weight loss of more than 5 pounds or 2.3 kilos since the start of pregnancy.
If you're experiencing fever or diarrhea in association with the nausea and vomiting.
Or if, as a result of the nausea and vomiting, you're experiencing feelings of hopelessness or wanting to end the pregnancy. Another question we commonly get is this likely to happen in subsequent pregnancies? And unfortunately, the answer is yes. So, is there anything you can do to prevent it next time around? Well, making sure you're taking a prenatal vitamin with folic acid at least 1 month prior to conception can reduce the risk of fetal malformation and may decrease the frequency and severity of nausea and vomiting. B-complex vitamins taken pre-conception and in early pregnancy may also reduce symptoms of nausea and vomiting. Additionally, if you have heartburn or acid reflux pre-pregnancy, getting these symptoms under control before you get pregnant may reduce the severity of symptoms while pregnant. And if we know you're at high risk, you can consider starting doxylamine peroxidine, or Diclectin in Canada, at the onset of pregnancy to prevent your symptoms from snowballing out of control.
So let's do a quick recap. If you're experiencing nausea and vomiting of pregnancy, you can stop your iron-containing prenatal vitamins during the first trimester and substitute it with a kid's chewable vitamin and folic acid. Iron requirements do not increase in the first trimester, so unless you have significant iron deficiency going into pregnancy, it's safe to avoid iron as it can often worsen the nausea and vomiting.
And this is an important message, ladies. Eat whatever pregnancy-safe food appeals to you. There is no evidence that short-term dietary deficiencies during pregnancy will have any long-term consequences on your pregnancy. I know in all of my pregnancies, I could not eat anything green. So I got through the first trimester mostly by eating nachos.
Nachos. Don't hesitate to give ginger a try. And Gravel actually makes a nice organic ginger lozenge that you can suck on, or there's tons of ginger candies out there. Also, those lemon candies can be quite helpful.
Acupressure may be helpful. And if your symptoms are mild and you're wanting to avoid medications, you may want to invest in a pair of C-bands. We'll link to that in the show notes below.
And if you're into cognitive behavioral therapy, give it a go. There's definitely no harm and lots of potential benefits beyond improving your nausea.
So we hope you found that helpful. We've put links in the show notes below to some of the recommendations, and we hope that whatever you do to get through the nausea and vomiting of pregnancy helps you manage your symptoms. And always talk to your care provider if you have any additional questions about what you should do and what's safe in pregnancy. If you enjoyed listening, please head over to iTunes, subscribe so you don't miss any new episodes, and please leave us a review. If you found this helpful, take a screenshot and share on social to help other mamas access this information.
Check out our website at www.shefoundhealth.ca and join our community. We send out weekly emails and release new content focused on this incredible time in your lives. We'll also be sharing exclusive offers, so be sure not to miss out.